So this is as I mentioned in the intro, this is a newer part of our agenda for these kinds of labs, and that is really talking about the reimbursement, coding, and barriers to doing these procedures. One of the frustrations I always had when I came to courses was, oh, that's a really cool procedure, and then you get back and you realize no one covers it, or the reimbursement's terrible, and it's really hard to figure out all of the gymnastics as far as site of service, which payers, et cetera. So what I'm going to do is basically just lay the foundation about how we think about things. And this is really not meant to be a lecture at all. This is an open discussion. I'm going to want input from Dr. Beal, Dr. David, Dr. Shawnard on a lot of these issues because we all struggle with this. And so I think it's important we just have an open conversation. So I'm going to start out with the posterior spinal elements, two of the procedures you've seen already regarding the facet joints and the sacroiliac joints. And my disclaimer is this: I am by no means a coding, billing, or reimbursement expert. In fact, I was at UCSF for 6 years, and I left 5 years ago into private practice. I knew nothing really about coding and reimbursement because when you're in academics, it's basically RVUs, and you just go in and get your beans, and you try to get incentive pay. But when you're in private practice, you obviously have to take into account every single dollar you get in reimbursement and every single dollar you owe as far as costs and expenses, et cetera. So it's really been a learning journey for me, and I owe a lot of that to Dr. Beal because he's helped me understand some of these concepts, and really it's kind of helped shape where reimbursement is going. So he and I do a lot of letter writing, conversations with CMOs of medical payers to help us have access to these therapies. And that's one of the most important things we can convey to you guys is nothing is given. You have to fight for it. You have to be an advocate for the therapies that you find safe and effective for our patients. So we encourage you to do this. So we're going to talk about the process and challenges of these procedures. So I'll start out. I just grouped it up by the anatomical structures, the facet joints. Doug already showed you the RFA. I think this is something everyone's pretty familiar with as far as the coding here. So the cervical, thoracic, lumbosacral, medial branches, and facet joint injections share the same code, 64490 through 5. And the ICD-10 codes that are eligible vary from place to place. So as you guys, I'm sure, are very aware, as far as Medicare areas, so the Medicare administrative contractors, the MACs, are what dictate what works for your particular area from CMS patients. And then, of course, you have the individual payers for the regions. So there are 12 different MACs across the country, and when I go give talks all over the country, I hear totally different things as far as what codes are allowed and what diagnostic criteria are allowed, because that's what it is for that particular MAC, and where I am in Northern California is completely different. So it's really important you look up the CMS website, Palmetto, Noridian, depending who the administrative contractor is, to understand what the criteria are to facilitate a radiofrequency ablation dependent on the outcomes from the medial branch block. So, Doug, for me, it's like 70 or 80%, depending on the payer, of relief for a few hours. What do you guys? You're in Oklahoma. We got Washington State. What do you guys hear?
2 blocks.
You want to get a microphone?
For us, it's 80%, 2 blocks separated by points in time before we can go into radiofrequency ablation. And that's primarily based on, so for you guys that collect data, this is primarily based on data that's been collected and published, and people say, well, I like to inject the facet joint better. I can say that too and often do. Doesn't mean that you'll get paid for it. So this is one of the things, whenever you collect and publish data for the purpose of showing efficacy, which is really what we're doing, let's make sure that's what we're doing, and we're not trying to have any other ancillary motives to try to do that. But it's right. It varies according to the Medicare administrative contractors, the various MACs. And each one of these have different rules of the road. The rules of the road are published in the local coverage determination, the LCD. And that's a very important point.
Yeah, and I'll just add as well that the thing we're looking at is percent relief, as Doug just said, 70 to 80%, depending on whatever. I said 70, he said 80%. But where we're going in the future, guys, which is really important, is different outcome measures, whether that's an ODI, whether that's some sort of, get up and go test, duration test, or, whatever else, not necessarily for these procedures. But what these insurance companies are really interested in is getting as much of an objective measure as possible. Because the truth is, we can all fudge and feign some of these percent reliefs to get what we want. No one wants that. We don't want to be saying something that the patient isn't saying. But the truth is, if somebody gets 65% relief and the patient really wants it and the criteria is 70%, you're sitting there going, oh, what do I do here? So, and then you have to kind of convey what the criteria are. So it puts us in an awkward position. It puts the patient in an awkward position. But we really encourage going forward is really looking at more functional measures, because we do think that's going to come down the pike. And then as far as radiofrequency ablation, it's the 646 code. So everything's pretty categorized fairly well in the CPT coding. So current procedural terminology. And so 646, 33, and 34 for the cervical, 35, and 36 for the lumbosacral. Any questions about the facet joints before we go over to the sacroiliac joints? I think most of us understand the nuances there. A lot of different societies do a really good job teaching the procedures and, of course, the coding with facet interventions. All right, as far as the sacroiliac joints, you saw Dr. Rich do the arthrodesis, which is the bottom here. So I sort of went from least invasive to most invasive. A sacroiliac joint intra-articular injection using image guidance 27096. Again, your ICD-10s can vary depending on where you are. For us in Northern California, we have sacrococcygeal disorders and 53.3, or sacroiliitis, which would be a radiological finding of inflammatory aspects. The newest two CPT codes are the next two, and that's really for the radiofrequency ablation. Just like what we saw for the facet joints, 2 years ago we obtained the lateral branch blocks 64451. So that's the technique of walking down the sacrum lateral to the S1, S2, S3 foramina, and then injecting small aliquots of local anesthetic, generally 0.5 mils of 0.5% bupivacaine or less, even 0.3. And then, of course, if you have a positive diagnostic there, which is generally a 50% reduction in pain or greater, you can go on to a radiofrequency ablation, again, newer code 64625. And then as Brian just demonstrated, we have the minimally invasive sacroiliac joint arthrodesis. There is an open sacroiliac joint arthrodesis code 27280. But since this is an image-guided interventional spine course, I didn't include that open code that the surgeons would do, Dr. Schonard, for example. Just a little history, sacroiliac joint fusion has been done for 50, 60 years with screws and open techniques. The idea is not novel, but the innovation has been making it safer, more minimally invasive, and more comfortable for patients. And that's what you're seeing generation after generation, and it's really taken off in the last 5 to 10 years. The diagnostic criteria do vary for me in my area. You need at least 2 sacroiliac joint interventions with or without steroid, inclusive of the top 2, actually. So as long as those provide at least a 50% reduction in their pain, they are eligible. And then, of course, ruling out tumors, fractures, and ensuring that they have 3 out of 5 positive signs on physical examination. Of course, that precedes all of this. Then they are candidates for arthrodesis. Now, one of the hot topics coming up, it's a current discussion since it's April of 2022. Coming next month, we're going to be talking about the posterior approach, which was not demonstrated, but many pain physicians do perform. And there's a discussion right now of whether they deserve a separate code because of the approach. And I'd love to hear Dr. Beal's conversation points about this, where he stands and where we might be going.
So just a couple of comments on that. So the posterior approach, that's one approach. Typically we have a lateral approach, a posterolateral approach, posterior approach. Does anybody know how many approaches that have been described in the history of SI joint fusion? What? 9. So there's 9. Absolutely, that's the right answer. There's 7 that are used commonly now. Not commonly, I think maybe traditionally. So to single out a single approach, so what is a posterior approach? The first posterior approach, the first SI joint fusion was described by a guy called C.F. Painter in 1908.
Okay.
right? So it's been done for 100+ years. It seems like it's been around for a while. And we have posterior approaches. We put in cortical dowels, allograft dowels. We have screws. Fuchs and Rule did great distraction arthrodesis. Wilkes, classic article, big conical screws with great fusion demonstration. And so I really don't see any purpose to single out a single approach, except insofar as to ask for data and contributions of that data to determine whether or not it has any difference in safety and efficacy as compared to everything else. So I think that's where we live and die. So, you know, that's what Dr. Schonard and I were discussing last night, talking about trying to collect all of our data. We're big in data collection, try to measure everything that we do for the purpose of figuring out. It's like a weather vane. If you know where you've been in the past, you'll know where you're going in the future. And if you don't like the direction, change it. And if we have data that we collect and it's good safety and efficacy data, then we know we're on the right track. And so that's what I hope people apply instead of trying to single out an approach. It feels to me, and I'll say this because other people may not be able to say it, is I feel like the posterior approach is being singled out, trying to target it out for some reason that's maybe beyond my comprehension. And I've been a big advocate for the posterior approach. Having said that, I haven't done a posterior approach in 4 years. Most of my SI fusions are like what was demonstrated by Dr. Rich, the lateral approach. So I'm not a personal advocate for it. I'm a professional advocate for it, just like I'm an advocate for other areas of SI fusion because, you know, you take something like SI joint RF, the Vanna-Klocher paper, it comes down, but it comes back, and it goes down when you repeat it. And this is not being critical of SI joint RF. I do at least a moderate amount of it, but I like to do fusions whenever it's indicated because the curve goes down in terms of pain decrease and functional improvement. It goes up, and it stays like that for a long period of time. Just a couple of opinions.
Yeah, those are great points, and you got me thinking about a lot of different things here. And one of the companies that's not being showcased today has done a really good job with evidence basis for sacroiliac joint arthrodesis lateral approach. And in fact, one of the papers compared arthrodesis to RFA, and while you see that RFA dip in pain scores and improvement in function, it comes right back up. And what you see with the arthrodesis is that pain reduction is maintained. And that's really what we're looking for is sustainable pain solutions. A lot of, we do injections all the time, local anesthetics, steroids, RFA, but those are temporary solutions. So finally having something that addresses a very ubiquitous problem, but long-term, is huge. I think our next couple of years here are gonna be very interesting in discussing which approaches, safety, who's doing it even, and what that reimbursement looks like. So that's why I'm kind of happy that we're talking about this. If you're not aware that these discussions are happening, you should be, because it affects what you do. And again, as Doug mentioned, the evidence basis is so big. Really, we got our first major, RCT 5 years ago now, 6 years ago, and now we have a 5-year follow-up, which really shows and demonstrates that this therapy works. Now everyone's jumping on. We have how many now companies? 25 plus?
So last time I counted, which was 2 weeks ago, there are 31 different companies that make SI joint fusion. Yeah.
So we're over 30 companies. So there's huge interest there. And certainly, if you're not looking for sacroiliac joint dysfunction / iliitis right now, you should be. Because again, the numbers vary, but 20 to 30% of low back pain is attributable to the sacroiliac joints. So you should be looking for these patients and identifying which patients are the best candidates for these interventions. Any questions from the audience? I know we have an international audience, so maybe the reimbursement may not matter as much, but again, super interesting discussion, even if you're not in the US. Any questions from the audience regarding the codes, coverage? Clear as mud, right? Doug, anything to add? Dr. David?
We do
Neil?
have some questions from the
great.
From the online the Zoom, but they do pertain more to the anatomy and also the procedure. But if anyone has any questions regarding billing and coding, please feel free.
We got a question behind you, Glenn. Yeah.
It may have already been applied, but right as of right now, is the posterior approach and the lateral approach being reimbursed for the same? It's the same code right now.
Correct.
Okay, and there's no issues right now with the reimbursement?
Currently correct.
Okay.
Yep.
Okay.
So I do quite a bit of posterior approach, and I've been reimbursed for that 27279 currently.
Okay.
The discussion from the AMA is going to happen next month. It wouldn't go into effect for at least 6 months. So for at least right now, that would apply, but we'll see what happens in May as far as the decision.
So the only differentiating point between SI fusion, and Ramo mentioned this, was 7.9 and 8.0. 7.9 is a minimally invasive code, and 8.0 is an open code. And so this is truly open. So if you're going to be coding for an open code, and we'll show that, demonstrate that, what an open procedure looks like. But most of the procedures that are done now minimally invasively, 27279.
Yeah, let me ask you that. So how do we differentiate minimally invasive versus open? How big does the incision need to be made to be in order to differentiate?
So, you know, all of these zones are a little bit gray, right? Because we're putting in, so the last SI fusion, I put 3 11.5 by 50 screws on one side. And these are big things that go in through a small hole. And it seems like you look at it and you think, wow, that's an open procedure, but it's not. It's an elegant, minimally invasive procedure with soft tissue dilation put in through a 12 millimeter incision. That when you close it up, it's about 1 centimeter. It looks, so the 27280 is truly open, direct visualization. And the 27279 is a minimally invasive, image guided, and this is in the code. And we'll show you the descriptions to the code. And one of the other emphasis that we'll make in the future is that you have to really mind the code, and you have to do what's in the spirit of the code to be able to code and bill appropriately for this. You don't want to have the procedure fit the code. You want to have what you do appropriately coded based on the work that's done. And if you are unsure, you can kind of crosswalk it. This is how the coding is, and new codes are developed. It's crosswalk to a similar procedure. And it'll benefit you to actually read the code and figure it out. And if you're doing something to document for the purpose of documenting for coding and billing, and if you're not documenting what it describes in the code as maybe you should be documenting, maybe you need to change the report or what you actually state what you're doing with your procedure to make sure all of this touches all points and bases in the spirit of the code.
Excellent. Any questions?
All right, so do you want to lead more, maybe ask the anatomic questions to Brian, and I'll go set up for the stem?
Yeah, let's do that.
Great.
Appreciate it. Thanks very much, Dr. Naidu. Brian, you want to grab a microphone just here, right there, and Dr. Beal and Dr. Sharon, if you want to chime in as well, please. A couple questions regarding the approach. What is the function of the screw? Can the screw be connected with other lumbar screws?
Okay, can you ask me that one more? What's the function of the screw?
Correct, and can the screw be connected with other lumbar screws?
Can it be affected with other lumbar screws?
Connected with other lumbar screws?
Oh, connected with other lumbar screws.
We're talking about more of a lumbar fusion construct.
Right, yeah, with like a typical pedicle screw P-lift type system. I think most of the screws, are typical most of the screws are kind of unique to the manufacturer, to whoever's using it, whether it's Verso, whether it's Genesis, or whatever company you're using. A lot of the screws typically are 3D printed. Sometimes where some screws are coming out are going to be fenestrated, where you can actually inject DBM down into the screw. And so once it's in situ, you can actually then put the DBM after it's already in. You can do that with bone cement too, in a situation where you have an osteoporotic patient, where you have like maybe a sacral fracture, and you could do that. But most of the screws are typically unique to each system. And that one that I demonstrated has a conus ending, which means so it has a backing to the screw. And when you're screwing it in, or when it's going in, it actually hits a stop where it hits, and where the stop essentially is the ilium, and creates, I think, more of a compressive biomechanical force when it's getting put in.
I just have a quick comment about that. Most of these are iliosacral screws, lateral, ilium to the sacrum. I think part of that question was connecting it to other constructs, and that's really Dr. Schonard's connection. From our view, we go iliosacral for connections to other screws. These are primarily aloilium. So S2AI screws. The S2AI screws would go from the S2 portion of the sacral ala to the ilium. And these are long screws, and you would typically need to put S2AI screws before you connect them. The other option is an iliac bolt. So these are, instead of going out to in, these are in to out. Alo-iliac.
Yeah, this screw technique is a supplement to and is not associated or linked to any lumbar or lumbosacral deformity construct. So this is supplemental and separate.
Yeah.
Excellent. Next question online was that can it be used for traumatic and non-traumatic SI joint or sacroiliac joint issues?
There isn't any data on this. There is advocate and one-off experience. But one of the things that we'll see further on in the talks is that as people do these procedures, you're going to find a variety, a heterogeneity of indications, a heterogeneity of population. But these screw techniques are designed for degenerative conditions. They're not designed for trauma conditions.
Excellent. If we can maybe just review for the audience as well as the audience online, the anatomical limits of this quote-unquote safe triangle for lateral SI joint fusion.
So the barriers that we talked about, the safe zones, are within the S1 corridor and the S2 corridor. Ventrally, you will have the lumbosacral trunk that becomes a lumbosacral plexus. It runs right over the anterior border of the sacral ala. Don't go there, right? And if you go anterior to that, the sacral ala is not the sacral body. So you'll see the sacral body, it has a border here on the lateral view. The sacral ala will be way out here. So you have to be way off target to get there. What else lives in that zone anteriorly? It's not only the lumbosacral trunk, lumbosacral plexus, but also the superior gluteal artery. So one of the common questions I get asked, are you worried about hitting something vascular? The answer is no. And my standard answer is if you hit the superior gluteal artery, we can't be friends anymore because that's way far anterior. And there was a time shortly after the earth cooled where I used to do angio. I'm from an interventional radiology background. And the superior gluteal artery is big. I mean, it's a large artery, but it's way far anteriorly. Posterior, you get into epidural space, you can get into the spinal canal, you can get into the sacral nerves, but that's way posterior. One of the things you have to watch out for is you have to go between the sacral foramina, and the sacral foramina, the lumbosacral junction, easy to see. The vestigial disc at S1 to S2 is right there. It's where the vestigial disc, it's where that line between S1 and S2 is, same as between S2 and S3. And so maybe you can't see it, maybe you're concerned about it, but let's remember we have three-dimensional visual spatial skills, and that third dimension is how far across you're going. So if you're worried about and you can't see this sacral foramina, maybe there's part of the 15% that have transitional lumbosacral anatomy, make their screw shorter. To get into the foramen, you need about 60 millimeters in most people, 50 millimeters in some smaller people. And if you're worried about it, use a 40 millimeter screw. You can put it all the way across, get a nice, secure stabilization laterally without even have to worrying about the foramen.
I think the only thing I would add to that is that's why I think we started with the Jamshidi, right? Because the Jamshidi, and I can't remember when we came up with that, but we kind of came up at the same time. But you know, the Jamshidi, you can directionally control it, So if you can get it anchored and get it started, if it's not going in a way you want, you can turn it, you can get it directionally controlled to where you want, and then really everything after that kind of plays off of the jam sheeting.
So rigid access is what Dr. Rich is talking about, and this is an orthopedic principle. You start off with something directionally controlled, rigid, less invasive, and then over the K-wire, the cursor wire, or whatever you have, once you are able to establish the right direction and get the K-wire, the rigid access in the appropriate spot, case is over basically. You put the screw over the top of this, and once you've established that directional control and established your target, you're good to go after that. This is primarily, we're taking this directly from the orthopedic principles, the AO principles.
So when you noticed when Dr. Rich was doing his procedure, he took multiple x-rays in multiple views to confirm three-dimensionally where he was. And so when he's coming through from the lateral side, he was seeing the anterior sacrum. He was seeing the posterior sacrum, so he knew his vasculature was in front of the anterior line. He knew his dural sac was posterior of the posterior line. And he was looking for the neuroforamen so that the jamsheedy would go between S1 and S2 neuroforamen. It's in solid bone. And you do the same thing going between S2 and S3 so that in all of your views, you know where your jamsheedy is and it's in safe bone.
One question I had, Dr. Beal, was you were talking about the vascular structures that are there. Ventral to the anterior body of the sacrum, we know that's a no-no zone. But behind that, there is that superior branch of the superior gluteal artery that's kind of in that relative area. Is there a posterior border that you're kind of staying away from as it rides along the ilium? Or are you even worried about that artery because it's a much smaller artery than the superior gluteal artery?
Yeah, the second one. I'm not even worried about it. So sometimes you'll get bleeding, but in the hundreds of cases that we've done and seen, you can hit that artery, and that artery is on the, look, if you hit the superior gluteal, there will be audible bleeding, just like the femoral artery, and it's very difficult to control because of the soft tissue depth. If you hit that posterior branch, it doesn't seem to cause a problem. The posterior branch to me is the same as hitting a radicular artery in the spine. If you go extrapedicular, peripendicular, you can hit these radicular arteries about the size of maybe a number 2 pencil lead, and they bleed. I mean, if you have a cannula in that artery, you'll have to duck so the blood hits the fellow and not you. But whenever you get a little bit of pressure there, because it's an artery, it closes off. It doesn't appear to cause much of a bleeding problem. And most of the bleeding problems, in my experience, happen whenever you, instead of dilate, you cut the muscle. And then that can really give you the persistent ooze bleeding that can give you the hematoma. So I would really focus functionally on trying to preserve as much as the muscle, dilate it rather than cut it. And that posterior branch, don't worry about it.
And Doug, I would like to add to that. You know, I like to talk about bad outcomes or things that happen. And when I did a case, I had a case where I had bleeding like that. And what I really found out was that my, what I call the tissue protector was not perfectly, I let it slip back and it wasn't up next to os. So when I was coming in with the screw clipped muscle. And as I pulled everything out, I started getting bleeding. Now it wasn't like arterial bleeding, but it just kept coming. And so I thought, okay, I had to figure out what happened. And basically what I did is I opened it up like I would on any other type of procedure, and I saw it and bovied it and controlled the bleeding and then closed it, and that was it. But I think that's why I learned to make sure that those dilators are staying flush up against os. As long as they're flush up against os, then you know you're safe when you're coming in with the screw.
Okay. All right. Well, let's maybe conclude with that last comment with Dr. Rich. I think we're pretty much ready over there in the lab.